Hello, my dear friends. I'm Dr. Vaishali Bharambe. I've been teaching anatomy for more than 25 years and I love it. Today, we are going to be discussing the gross anatomy of anal canal. Anal canal is the lowermost part of the alimentary tube, extending from the lower end of rectum to the anal orifice. It extends from that 0.2 to 3 centimeter below the tip of coccyx to the anal orifice, which is 4 centimeter below and in front of the coccyx. You can see that anal canal is quite a short structure. It has some peculiarities. It is closed all the time except for purpose of defecation. It is surrounded by sphincter ani muscles and it is a non-peritoneal structure, barely 3.8 centimeter in length. It's related in front to the perineal body, behind to the anococcygeal body, on each side to the ischiorectal fossa as seen here. So it's quite well supported from all sides. Friends, if you are enjoying this lecture, do like and subscribe to my channel. It will encourage me to make more of such informative lectures. So now is the time when all of you should be getting your color pencils. I know you feel like a small kid, but believe me, I personally, even at this age, learn by drawing. So it really helps because it keeps you entirely occupied. So now let's see if you can draw the rectum and anal canal, and on the side here are the ischial walls, okay? Lined by the obturator internus covered by fascia. Here's the levator ani now coming in, forming the pelvic diaphragm through which the rectum is passing. On either side, the rectum anal canal is supported by the ischiorectal fossae. And now let's divide the anal canal with the help of two lines, the pectinate line and the Hilton's white line, dividing the anal canal into upper, intermediate and lower parts, each being 15 millimeter and the lowermost part being 8 millimeter. So we've got our basics in place. We still have to have the sphincters. So now remember, your gut tube is always having two layers, an inner circular and outer longitudinal. So this inner circular layer of rectum and anal canal thickens to form the sphincter ani internus, which is an involuntary smooth muscle. Okay, about 2.5 centimeter long and 2 to 5 millimeters in thickness. This is surrounded by sphincter ani externus, okay, divided into deep superficial and subcutaneous groups. Actually looks like a single muscle. It's a skeletal muscle which is voluntary, supplied by inferior rectal nerve and S4 nerve. And in between them, remember there's an intersphincteric space which is often explored by surgeons in various surgeries. The upper part of internal sphincter, the deep part of external sphincter, along with the puborectalis. See, here's the puborectalis, here's the deep part, and in the wall is the internal sphincter. Together they form the anorectal ring. So here's your anorectal ring. And if this ring is damaged, it will lead to fecal incontinence. You saw the inner circular layer forming sphincter ani internus. What happened to the outer longitudinal layer? The outer longitudinal layer descended down, joined with a levator ani muscle to form a conjoined fibroelastic sheath. This sheath descends down, splits and gets attached to the skin or passing through the subcutaneous sphincter ani externus to form corrugator cutis ani muscle. It attaches itself to the Hilton's white line, forming the anal intermuscular septum. This longitudinal muscle is said to provide pathways for spread of perianal infections. Now let's come deep to the submucosal layer. Okay, so we've done the muscle. In the submucosa, you find there are two plexuses, an internal venous plexus and an external venous plexus. And these plexuses drain via veins in varying directions. The upper part of the internal venous plexus drains via superior rectal veins. The middle part into middle rectal vein and inferior part into the inferior rectal vein, so the external part. Remember that the internal and external plexus are in communication with each other. So you find that the superior rectal vein drains into portal system, the middle and inferior rectal veins drain into inferior vena cava, and therefore your internal venous plexus here becomes the site where the portal and the cable blood vessels meet, a site of portocaval anastomosis. This lot of blood vessels which are found in the wall of the rectum, okay, in the form of a ring, form what is called as annulus hemorrhoidalis. So let's now understand a little bit more about the wall of anal canal and discuss a little bit about hemorrhoids or piles. So, upper part of the anal canal is about 15 millimeters in length. It's limited below by the pectinate line. The wall of it shows presence of such longitudinal columns which are called as anal columns. These are called anal columns of Morgagni. They contain radicals of superior rectal veins. You have to imagine that inside them there are superior rectal veins. What are anal cushions? These are parts of the mucosa which are containing core of connective tissue containing a lot of blood vessels which come inwards and help in the fecal continence. They form something like a seal. Okay, they're a very important part of fecal continence mechanism. These superior rectal veins, in the presence of portal hypertension, can become dilated. Some veins getting dilated before others. Those veins that bulge inwards first are called primary piles. They form primary piles. In which position will you get them? You get them in left lateral, right anterior, right posterior position with the patient in a lithotomy position. So let's briefly ask ourselves, what is piles or hemorrhoids? Hemorrhoids are swollen varicose veins in the rectum or anal canal. Why do they form there? Why not somewhere else? They form here specifically because they are completely going against gravity without help of valves. There are no valves here. They are piercing the wall of the rectum posteriorly so that when you put a lot of pressure, the veins get compressed here. And the portal hypertension itself is a major mechanism. So it has to push blood against portal mechanism, resulting in a lot of stasis in veins, resulting in varicosity. So let's talk about internal and external piles. So there are some piles or hemorrhoids which develop above dentate line, which are called internal hemorrhoids, which develop below dentate line are called external hemorrhoids. Internal aligned by mucous membrane, external aligned by skin. So you have pectinate line, above it will be internal pile, below it will be external pile. Above it lined by mucous membrane, below it lined by skin. Above it, because there is autonomic nerve supply, it's painless. Below it, it is very painful because it's supplied by inferior rectal nerve. And all this more is information about this. You can pause the video and discuss, some of which is more clinical than anatomical. If you're enjoying this lecture, do like and subscribe to my channel. It will help me to encourage me to create more of such informative lectures. Continuing our discussion of the upper part of anal canal, you saw anal columns of Morgagni. Now they are joined below by horizontal lines which are called anal valves of Moll. Together they form the pectinate line. There are also anal papillae, anal sinuses. What are these? Let's take a look. So this is the anal valve that you just understood. The space or the depression above it is called anal sinus, into which you can clearly see an anal gland opening. So there are glands in the submucosa in the anal canal which are draining into the lumen. So these anal glands are relevant because they can get infected and are a major cause of anal fistulas. This region is having an autonomic nerve supply. So what is an anal fistula? Anal fistula is an abnormal tunnel that gets formed such that it connects the lumen of the anal canal to the surface of the skin of buttock. You can see it here. Connecting the lumen to the surface of the skin. It's a tract. Okay. So most of the anal fistulas are in reaction to anorectal abscesses bursting on the surface. What are the types of anal fistulas? Let's understand this. Here's your sphincter ani internus, here's the sphincter ani externus. Okay, this way here is the puborectalis muscle. So you can have a submucosal, you can have intersphincteric, transsphincteric. Try and use the image to get the idea about these in your mind. Suprasphincteric and extrasphincteric. parts. Also, these are different types of fistulas. Let's discuss them in brief. This intersphincteric here connects inwards into the anal canal, passes through and in between the sphincters to open on the surface. This is the most common type of fistula. Then you have a transsphincteric. Okay, so it's going to pass through both the sphincters, connecting again the lumen to the surface. It extends and passes through the ischiorectal fossa. Then you have suprasphincteric. So it not only passes through the sphincters, but ascends up and passes through the puborectalis muscle and then descends downwards to the perianal skin. So the tract is somewhat horseshoe shaped. Then let's talk about extrasphincteric. This one does not bother about the sphincters at all. It communicates the anal lumen above through the sphincter muscles down to the surface. This is extrasphincteric. And you have something called submucosal, which does not touch the sphincters at all. It passes through the mucous membrane and submucosa to communicate the lumen to the skin on the surface. So we come to, so you saw fistulas, you saw hemorrhoids, but we've discussed the anal canal only till the pectinate line. Let's understand why is this pectinate line so discussed. It is situated at the junction of upper and the middle part of anal canal. It's a mucocutaneous junction, developmentally the junction between the endodermal and ectodermal parts of anal canal. It is important because it's a watershed line. Everything above is draining upwards into the inferior mesenteric vein, portal vein, or getting supply from the gut. Nerve supply autonomic, lymphatic drainage upwards. And remember, because it is comparatively less sensitive, it is this area in which you can put in a needle in a non-anesthetized patient for treatment of some hemorrhoid. Whereas, okay, so the middle part called as the pecten is bluish pink and it has somatic nerve supply. The part above is plum red. The part below is bluish pink. Okay, this one. And it is limited below by the Hilton's line or called as the Hilton's white line. Here you see a lot of color contrast between the lumen and the external skin. It's the point where the anal intravascular septum is attached and it's the lower end of internal anal sphincter. Surgical importance is that ischiorectal abscesses open below the Hilton's line. Lowermost part is barely 8 mm. The skin here is brown to black. It's getting a somatic nerve supply and you can see the skin around it much folded because of the corrugator cutis ani muscle that got formed because of attachment of the longitudinal muscle of rectum and anal canal to the skin. We've discussed this earlier. This one. So finally, just one last few lines here. The epithelium also varies. The part above pectinate line is simple columnar. Below it, stratified squamous, non-keratinized, no sweat glands, no hair. But the last part is pure skin, stratified squamous, keratinized epithelium with the necessary glands and hair. So, arterial supply to rectum anal canal best understood in one go. It's supplied by the superior rectal artery which divides as it enters into one left and two right arteries, right anterior, right posterior. The middle part gets supplied by middle rectal, lower part gets supplied by inferior rectal branch of internal pudendal artery. Nerve supply, like I said above, is by sympathetic and parasympathetic, below is by somatic. Sympathetic usually maintains continence. Parasympathetic facilitates defecation. Lymphatic drainage, the upper part drains into inferior mesenteric lymph nodes. Middle and lower part drains into the internal iliac lymph nodes and lowermost part drains into superficial inguinal lymph nodes. Anal canal is surrounded by a lot of spaces which promote abscess formation. So, these spaces, subcutaneous spaces, submucosal, intersphincteric, ischioanal, okay. So, these are perianal spaces. Finally, there is a lot of variable interpretation of anal canal by different people. For example, the surgeons say that anal canal is all three parts, whereas the anatomist says that only the part below the pectinate line is the anal canal. So that's called the anatomical anal canal. And finally, the real anal canal, a lot of people say, is the first and the second part. The third part, according to them, is just the skin. So I'll leave it to you to interpret your anal canal as long as you understand it. If you enjoyed this lecture, do like and subscribe to my channel. It will encourage me to create such informative lectures. Thank you. I'll see you across the screen in the next surgical anatomy lecture.